Hi, this is Crystal. Thank you for listening to our project on improving the process of assessing and documenting a learning needs assessment in an ambulatory cancer center. You will also be hearing from Tracy and Sarah throughout this presentation. This is an image of the Norris Cotton Cancer Center in St. Johnsbury, Vermont. We are an outreach oncology center providing medical and radiation oncology to patients in the North Country of New Hampshire and the Northeast Kingdom of Vermont. This is an image of the infusion suite at Norris Cotton Cancer Center in St. Johnsbury. We provide care to patients with all types of cancer utilizing advanced technology and state-of-the-art equipment in an environment that is close to home for patients and their families. We offer comprehensive care in a small clinic setting with 6 infusion chairs and 2 private rooms. In the fiscal year 2014, our medical oncology section alone had almost 3,500 patient appointments. Although we are a small outreach center, we offer comprehensive care to our patients and their families. Our medical oncology section consists of a team of physicians, nurse practitioners, and certified oncology nurses. Others in our team include an in-house pharmacist, social worker, certified oncology dietitian. We offer palliative care, spiritual care, massage therapy, and Reiki. As part of Dartmouth-Hitchcock Medical Center, our global aim is to provide our patients with the best care in the right place at the right time, every time.
The specific aim of this initiative is to complete learning needs assessments in the patient's electronic medical record to provide patient teaching that is specific to their healthcare needs by May 2015. The balanced scorecard displays the strategic plan for our microsystem. It gives a visual display for performance measures in 4 key areas: the key process, satisfaction versus need, financial and innovation, and learning and understanding. It is important to understand our current position in each of these because it helps us to plan for the future. When we talk about the key processes, it highlights what we must be good at, or in more simple terms, the organizational goal. The aim is to provide our patients with the best care in the right place at the right time, every time. Our measure is patients coming in will have a current learning needs assessment documented in the electronic medical record. The table here shows a slight increase of new patient assessments and completed. In 2013 and 2014, we were still below the goal. Our action plan is that learning needs assessments and quality improvement is underway with a team. As we look at innovation and learning, it highlights changes that need to be made to implement and sustain improvements within our microsystem. Our aim is to create an environment where nurses are able to leverage technology to optimize patient care. As we look at the table, it displays the staff comfort rating with using the electronic medical record and nursing comfort with completing nursing assessments. Look at the blue bar. It shows a very low percentage of comfort level for nurses using or completing the learning needs assessment. The brown bar displays that we have about 20% nursing comfort using the electronic medical record. Our goal is to reach 100%. Our action plan is to develop a group of super users, have them identified and available on all shifts to help with nurses. Financially, this area highlights the impact of negative outcomes on the microsystem when we look at money. The aim is to be fiscally responsible and stay within the NCCN medical oncology budget. Canceled treatments slightly decreased between 2013 and 2014. The goal is to be less than 10% by 2015. Overtime days a month were the same between 2013 and 2014, and our target is to be less than 5 days by 2015. We have no specific action plan here because our hope is that the financial impacts will decrease with implementation of this project. Satisfaction versus need. Are we meeting the needs of our patients, and are they satisfied with their care? Our aim here is to create a process that establishes the patient's educational preferences, allowing nurses to personalize patient education. As we look at the graph, the brown bar shows patient satisfaction with nurse communication, and the blue bar shows whether patients feel their educational needs are being met. From 2013 to 2014, patients felt that they had good communication from nurses, but that their learning needs were not being met. By 2015, our goal is to have a balance between the two. Our action plan to achieve this goal is that learning needs assessments and quality improvement team will be underway and working on this project. Here we can see our current performance, and you see that only 5% of new patients coming into the clinic are having a learning needs assessment completed. Our expectation and the standard is to have 100% compliance. Our microsystem is far from reaching this goal currently. As we've talked about, our results so far show that we have a need for quality improvement in this area. Learning assessments are not being completed, so we are not providing patient education that meets their personal needs. Assessments are not being completed to evaluate the patient's learning needs and provide education that is appropriate for them. This is a Joint Commission expectation, and we need to work towards this goal.
We recognize that there are many barriers to implementing change in a microsystem. Highlighting 3 of the most concerning barriers in this project include: 1. Fear of asking difficult questions. Asking patients about literacy may make patients and nurses alike uncomfortable. 2. Lack of education or knowledge. Nurses in this microsystem have expressed insufficient training in this aspect of the medical record. And 3. Undefined goals and objectives. This need has not been made a priority until now, and the requirements have been unclear. By providing patients with complete and current information, it creates an atmosphere of trust and enhances the patient-physician relationship. Knowledge empowers patients and helps to ensure that patients are making informed decisions about their care. As healthcare providers, we need to recognize the importance of providing patients with education. We also need to identify barriers to learning, involve them in their care, and in setting goals. We will provide the best education by being clear and concise in our teaching and present manageable amounts of information. To provide good patient education, it is our responsibility to identify potential barriers to learning. Some of these include physical symptoms patients may be experiencing. Language, culture, literacy, and financial factors should also be considered. A patient's support system or lack of a support system can also be a barrier. Understanding a patient's knowledge and any misconceptions they may have about their disease and treatment plan is important, as is educating patients in a quiet environment with minimal distractions.
Here you see a screenshot of the current learning needs assessment in the electronic medical record that nurses are expected to complete. It categorizes the assessment to primary learner and co-learners. For each learner, required fields include name, relationship, barriers to learning, language, is an interpreter needed, preference for learning concepts. As we assess the patient's learning needs, what are your concerns? What are your goals for learning? Do you understand your illness or condition? What are you most interested in learning? We also want to talk to the patient about what they're concerned about. What do you feel you need to know to take care of yourself? What knowledge do you have about your illness currently? What knowledge would you like to gain through education? What are you interested in learning? And it's also important to learn from the patient Are they able to care for themselves at home? Is it important to educate somebody else in the family who will be assisting with their care? We also then want to assess the patient's learning style. Questions that we might ask them are, how do you learn best? Are there any issues that prevent you from learning? Do you prefer to learn from listening, watching, or doing? Do you have a language preference when it comes to understanding education? The last focus point for a learning assessment should include the patient's readiness to learn. It's important to understand how the patient feels about learning right now and the barriers that they might have to learning. Are you motivated to make changes based on what you're learning? Are you motivated to learn the information you need to take care of yourself? And how important is it for a family member or caretaker to receive education on information to care for you?
Understanding that assessing patients' learning needs should be done at the first visit, we mapped the process of a new patient visit. This revealed that patients are asked to arrive early, 30 minutes before their visit, to allow the nurse time for the assessment. If the patient does not arrive early, the nurse conducts only an abbreviated assessment. This is a potential break in the patient care flow and may be contributing to the low percentage of completed assessments. To better understand all of the factors that contribute to learning needs assessments not being done, we brainstormed other contributing factors in the categories of staff, patients, environment, policies and procedures, technology, and providers, using a fishbone exercise. Though factors appear on one bone of the fish, there are interrelationships that create a web of causation that increases the complexity of the problem. Nurses are reluctant to ask patients about literacy, and patients are uncomfortable talking about illiteracy. From an operational perspective, the nurses feel that they don't have enough time to complete their assessments. This cause is related to a lack of dedicated nurse appointment before the provider visit. This contributes to there being times when the nurse isn't present for an initial new patient workup. Thus, the assessments aren't completed. Finally, regarding the electronic medical record functionality, there is no nursing admissions assessment tab in the ambulatory visit navigator. So there is a relationship between the nurse feeling uncomfortable with the electronic medical record and the ease of accessing the required sections. Based on the information obtained during the fishbone diagram exercise, we set the following goals for the project. We want to assure that nurses have a sufficient amount of time to complete their assessments. We want to increase nursing knowledge and confidence regarding how to use the electronic medical record to document a learning needs assessment. And we want to achieve 100% of new patients having a learning needs assessment documented in the record. We reviewed the available data and confirmed that the perception that patients were arriving at or near the time of the provider visit was accurate. As the run chart displayed here shows, patients arrive on average only 5 minutes before the physician visit. Therefore, we knew that we would need to take action to allow the nurses sufficient time to complete their assessments. We employed this model for improvement, displayed here, to guide our work. This model helps to clearly articulate the aims, key metrics, and improvement ideas. The plan, do, study, act cycle is used to test and assess the impact of changes on a small scale before a full implementation and leads to increased success. This slide describes, at a high level, the aim, measurements, and change ideas for our project. As you can see, our aim is to have a learning needs assessment documented in the EMR for all new patients. The metrics we will monitor to understand our performance is the percentage of new patients who have a completed learning needs assessment in the chart. As we described earlier, our current performance on this metric is well below the target. We will be implementing 2 change ideas. The first is adding a scheduled visit with the nurse. The second is providing education and support to nurses pertaining to the learning needs functionality in the electronic medical record. This table provides additional details about PDSA number 1, scheduling an appointment with the nurse 30 minutes before the physician visit. Using this format to plan our PDSA helps us to identify the people who will be impacted by the change. In this example, the secretaries are responsible for scheduling the visits. Thus, a majority of the planning is around secretary education on the new workflow. The bottom of the table describes the data that will be collected during the PDSA to understand if the change is successful. Since at this time we are not requiring that nurses complete the learning needs assessment, we are using the standard initial nursing assessment as the proxy measure to understand if nurses have adequate time to do their work. After careful planning, we carry out our initial pilot. During the pilot, we make observations and record initial data. During our observations, we learn that some patients are expressing resistance to the additional visits, and even when scheduled, don't arrive early. We also understand that the secretaries are confused about which patients need the visits. Therefore, there's inconsistent scheduling of the resource visits. Finally, we see through feedback from nurses that there's inadequate time in the nurses' schedules to see all of the patients. During the study phase, we further analyze our data. We want to look at patient arrival time using our run chart to see if we have changed or moved the mean of arrival time at all. We're also going to monitor, as discussed earlier, the percent of patients with the scheduled visit and the percent of patients who have the assessment documented in the EMR. This run chart shows that after the initiation of our PDSA, there is an improvement in patient arrival time. The mean is now closer to 12 minutes before the provider visit. This is still far from our goal of 30. We look further into our data and understand that when patients do arrive early, the nurse has more time and is more likely to complete her assessment. This tells us that we need to continue working on patient arrival time. We take the information that we gained during the study section of the PDSA and apply it to determine what to do next. When the nurse visits are scheduled, the nurses are more likely to complete their assessments, but compliance with scheduling the visits is good, but not at 100%. Therefore, we conclude that this change does have a positive impact on our outcomes, but we need to increase compliance. So we have two actions that we're going to take. The first being to reinforce the need for the visit with the secretaries, and the second to share data and our plan to continue this practice. We continue our work and monitor it regularly. After providing the reinforcement and continuing to track the arrival time, we're able to achieve an average patient arrival time of 30 minutes before the provider visit. It's critical that we continue to monitor this on a long-term basis to make sure that our system stays in control. You will recall that this project had three main goals. PDSA 1 achieved goal number 1, but did not impact numbers 2 and 3, shown above. To impact 2 and 3, nurses need to be provided education in accessing and documenting the learning needs assessment in the electronic medical record. We verified that a lack of understanding and comfort with the electronic medical record's learning needs assessment is related to percent completion of the learning needs assessment. Nurses who self-report more comfort with the electronic medical record, as demonstrated by the brown diamonds, in general have a higher rate of completion of the learning needs assessment in the electronic medical record, as shown in the blue bars. While overall completion rate is poor, it's lowest for nurses who express the most discomfort with the electronic medical record. PDSA number 2 will address this need.
PDSA 2 will show the importance of providing support directly to nurses regarding use of the electronic medical record. Our objective here is to increase the number of nurses who rate their comfort and proficiency with using the electronic medical record at least a 5, which is considered excellent, and increase the number of new patients who are having completed learning needs assessments in the electronic medical record. We'll do this by carrying out the plan that you see here, documenting any problems and unexpected observations, and begin to analyze data to figure out how we can best move forward. Data will be collected through questionnaires administered to nurses after the PDSA to indicate if there is any increased level in comfort with using the electronic medical record. And we will continue to monitor the percentage of new patients who are having completed learning needs assessments to see if it increases. After the PDSA, you see here that 3 nurses are now completing the learning needs assessment 100% of the time, and all nurses expressed an increased level of comfort with use when it comes to the electronic medical record. We're happy to say that our PDSA was successful. We will continue to implement and monitor the process, and we hope in the future to start to move the process into our established patient workflow.
This pie chart shows the percentage of new patients with a learning needs assessment in the chart reached 90%. However, as you can see, there are still many patients who do not have completed learning needs assessments. Next, we need to implement a process for our established patient population. There were many goals of this project. The first was to provide patients with individualized education based on information gained from assessing their learning needs. The second was to meet the Joint Commission requirements regarding learning needs assessments. And finally, we hope to increase nurse comfort with the electronic medical record learning needs assessment. We are well on our way to meeting our targets on these measures. Using the PDSA improvement methodology helped us to explore and mitigate barriers and challenges that increased our success implementing change in this microsystem. We can take the knowledge and experience that we gained during this initiative as we move forward to expand on the work we've done.